And good morning. My name is Ambrazo. I am the CEO and founder of MPN Advocacy and Education International. We have been around for many years. I have been around in the MPN space for 17 years. We host educational programs and provide advocacy efforts on behalf of the MPN community. During the pandemic, we chose to go virtual for obvious reasons. And because we are virtual, we have been able to reach so many more patients and so many more caregivers and other constituents. And today we are focusing on PV and ET, essential thrombocythemia and polycythemia vera. Our special guests today are Dr. Angela Fleischman in California and Dr. Andrew Kuykendall from Tampa, Florida. And I am going to introduce, I shared with them in our little practice session that we have over 5 pages of questions already that have come through from our registrants. Over 200 people have registered for this program. So I will be asking the questions after you hear a few words from them on what work they're doing in their labs currently. And then we will get right to the questions that you have asked. If you have other questions that I have not asked, and we will never get through all these in an hour and a half, please send them my way. And we always get them, and we will ask the appropriate person the questions as we get them. So Dr. Fleischman, would you like to go first? And Andrew and I will hide our screen. And so you will be the person out there and just share what's happening in your lab.
Okay. Hi, everyone. My name is Angela Fleischman. I'm a physician scientist in Irvine, California at UC Irvine. And I've been focused on myeloproliferative neoplasm since the beginning of my medical career. My particular focus has been on the role of inflammation in MPN. As we all know, people with MPN have increased inflammation, and that can drive many of the symptoms that MPN people feel, as well as I believe that it also plays a key role in the initial development of MPN, as well as the progression of MPN. And to further investigate this, we've been examining whether low inflammatory diets, such as a Mediterranean diet, could possibly be a low risk, low cost way of reducing inflammation in MPN. We've recently completed 2 feasibility studies with the purpose of just seeing whether MPN patients can adhere to a Mediterranean diet if given appropriate counseling. And now that we've established that it's feasible, we'll move on to much larger studies to particularly determine whether a Mediterranean diet could actually reduce inflammation and improve symptom burden in MPN. We're also investigating the role of antioxidant supplements such as N-acetylcysteine as a potential therapeutic in MPN, and we'll very shortly open up a clinical trial looking at N-acetylcysteine in MPN. We also have a study going on. A particular interest of mine is identifying why MPN runs in families. So we have an MPN family study for which we invite affected as well as unaffected family members in MPN families to sign up for the study and send us samples in the mail. So if you're interested in any of those, feel free to email me. Hopefully somewhere on the screen, they'll provide my email address. But if you have any questions or any particular interest, feel free to email me and I'll give you more info. So thank you.
That's fantastic, Angela. And you know, we get tons of questions about familial issues and is it a disease that can be passed through the family. And we do know lots of families. I know Dr. Wadley was doing some studies years ago, and I'm so happy you're doing this. We will get your email address out there during the course of this program. And so for the moment, we will now hear from Dr. Andrew Kuykendall from Tampa, and got both ends of the US here. And so Andrew, please share with us what's happening in your lab.
Yeah, absolutely. Thanks for having me. So I'm at Moffitt Cancer Center in Tampa, Florida, and I am a clinical researcher really focused on bringing some of these kind of novel therapies to the bedside and to patients. I think when doing that, you have to be an avid fan and proponent of those that are working in the lab, like Dr. Fleischman and her colleagues, and you really are looking to see kind of what developments are coming down the pipeline there in the lab, as well as we're looking at other disease states and disease entities that have some overlap to see what agents are working there and see if that's something that may actually be able to cross over to our patients and actually provide some benefit. So from the clinical research side, I think that we have a lot of areas of unmet need within MPNs. And I think for a long time, clinical trials have really been focused on patients that have myelofibrosis. And that's typically how, across the oncology spectrum, trials typically start in the most severe disease entity. And so, when we talk about solid tumors, let's say, lung cancer or melanoma, typically the initial studies are done in patients that have metastatic disease or have been refractory to initial therapies. And it's no different in myeloproliferative neoplasms, where we've really put a lot of our effort into studying what may work in myelofibrosis. And that's how like JAK inhibitors came down the pipeline. And certainly there's a lot of phase 3 studies right now in myelofibrosis. But I think we're starting to understand two things. One, we're starting to really have that technology or that research trickle down to clinical trials being done in polycythemia vera and essential thrombocythemia. And so you are seeing some agents that have shown efficacy in the MF space really being assessed specifically in the ET and PV populations. And I think we're also finding out that some of the pathology or the pathophysiology that goes on is really much different in ET and PV. And so this may be, it may be reasonable to not wait for things to really trickle down. We should be looking at things, individually early on, really in those disease states. And I think Angela brought up some good points is, I think that inflammation and the role of inflammation and some of these kind of low intensity, low toxicity treatments, are probably not going to have much efficacy in the later stages of the disease, but merely PV and ET may be our opportunity to bring some of these into the mix. And, I think that it's going to take not only great work done in the lab with good rationale and non-toxic therapies, it's also going to take some intelligent designing of clinical trials, because I think that regulatory bodies are somewhat averse to running clinical trials in patient populations such as PV and ET. And we're going to have to kind of reframe this discussion, because I think that's where the potential for disease modification, really is present.
I love that you brought that point up, Andrew. This has been in discussion with some of our colleagues over the last several months, the redesign of clinical trials. And, not only the redesign, but everyone wants to help and support the patients that participate in clinical trials, but we have to be, we have to include all of the people, a broad spectrum of patients, and not continue to get the same group over and over again. But these are discussions that we've been having for several months. So I'm glad you brought that up. So I want all three of us to be on the screen. I'm not sure how to do that, but I see all three of us up here. Well, I mean, I'd like to have larger pictures of all three of us, but I forgot how to do that. So bear with us, because as I said, we have one person out today who usually helps with this. But I do want to go to these questions. So there are so many. And one is, and Angela, you just mentioned about your study. Is there a concern that my children may have PV or another MPN because of my diagnosis? Is there any testing they should get done or monitor?
That's a good question. So I want to be clear in terms of the familial predisposition to acquire MPN. It's not necessarily that a particular gene the mutant gene is passed down. Myeloproliferative neoplasms, the JAK2 or paraticulin or MPL mutation is always acquired mutation. So you weren't actually, didn't actually get it from your parents. However, the tendency to acquire one of these mutations does appear to run in families. About 10% of MPN patients will report that they have a first-degree relative who also has MPN. So the risk is real. However, at the present time, there's really not screening that's recommended for first-degree relatives of MPN patients. However, what I usually tell patients is that, say your child comes up with a blood clot or they have increased platelets, that in an otherwise, a person who wouldn't necessarily have a family history of MPN would just be sort of shrugged off. But in that case, not to shrug it off, but take it a little bit more seriously. But in the absence of any blood count abnormalities or any clinical suggestions that a family member may have MPN at the present time, just random screening is not necessarily recommended.
And Dr. Kuykendall, do you have family members that have an MPN in your practice? Okay, we'll move on because I suspect he had a call out. So Angela, which somatic mutations are high risk for disease progression? Is there any evidence of that, and what can you share with us on that subject?
So many times people, in addition to their JAK2 or paraticular or MPL mutation, will have additional mutations. That's very common for MPN patients to have. And certain ones are characterized as, quote, high-risk mutations, such as EZH2, ASXL1, P53. I think there's a few. What other? I'm missing some other ones.
Yeah, I think in the recent, they did like a MIPS ET and MIPS PV recently looking at progression. And, there's kind of different mutations that are risk for progression to myelofibrosis and different ones that are progression to AML. And certainly, I think when we look at TP53, we worry about AML progression. And things like RUNX1, maybe a little bit of AML progression there. IDH1 and 2 may be associated. But then splicing mutations seem to be what came out as far as progression to myelofibrosis. And they're very rare to occur in PV and ET. And so when you looked at the relative risk of, and I think this came from Mayo, it was like 12 or 13-fold relative risk, but we don't often see splicing mutations in the chronic phase of these. So one thing I would say is it's a little bit kind of self-defining too. I think if I see a splicing mutation in a chronic phase ET or PV patient, I'm not thinking that patient's necessarily at high risk for progression. I'm actually thinking we probably need to take another look at the bone marrow biopsy because they might already have myelofibrosis at that point in time, or maybe pre-fibrotic MF or something a little bit more on the spectrum of later phase disease.
Okay, and how does the KIT mutation fit into MPNs? Can a high white blood count indicate a problem like mastocytosis with the KIT mutation? Yeah,
so in addition to MPNs, and Angela, if you want to take questions on systemic mastocytosis, be my guest. But I do see a lot of systemic mastocytosis as well, and I think that it's become something that has just because there's novel agents that are coming out that have been approved, there's a little bit more of a focus on this, as there should be, just like there was more of a focus on MPNs after ruxolitinib was approved. And so just like we see JAK2 mutations associate that with MPN, similar to CALR and MPL, I think this KIT mutation is something that's becoming intrinsically linked to patients that have systemic mastocytosis. And it's a challenge to, I would say not necessarily a white blood cell count being elevated, because I think that's more probably indicative of an MPN, but I think that's been the challenge, is finding clinical symptoms or signs that might clue someone into having mastocytosis. And it's why patients go such a long time, without getting diagnosed with that disease. And so more so for mastocytosis, I'd keep an eye out for kind of atypical urticaria, skin reactions, anaphylaxis, unexplained diarrhea, brain fog, Those are the types of like atypical symptoms that can be present in a patient that already has an MPN, that may mean that they have a concomitant, mastocytosis component to that. But I think that the mastocytosis itself is a tough entity, diagnostically.
So and I think it's important to distinguish that it's not necessarily like a progression of their MPN. It's in parallel. It's like they have two diseases that sort of sometimes travel together.
Okay, and that's what I was going to ask next. And so, is the KIT mutation does that always go hand in hand with the other disease, with the like mastocytosis?
So I think the easiest answer is to say yes. It's not 100%, but we do know that about 95% of patients with systemic mastocytosis will have a KIT mutation, and some studies have looked back on AML, MDS, MPN patients that have a KIT mutation, and they go back and look at the marrow retrospectively, and they do find that a significant proportion of those patients do have a kind of an underappreciated mast cell component that probably was there and maybe was kind of looked over. So I think by rule, if I do see a KIT mutation, I think that patient probably has some degree of systemic mastocytosis until proven otherwise. There are certainly patients that have KIT mutations where you can't prove that they have a mast cell proliferation component, but I think that's probably the exception rather than the rule.
Okay. I'm hearing from other patients that gout is associated with ET and PV, that both cause excess uric acid. Is this true, Angela?
Well, I guess one could say that any, gout is a pretty common disease. And one could say that any disease which increases inflammation could potentially increase one's risk of gout. Also, lots of cell turnover increases the uric acid and can then also precipitate gout. So I guess the answer is yes.
Yes. Can you stay with me on that for a moment? Because, as we said at the onset, you've done a lot of studies with inflammation, and I have several questions here for you specifically about diet, other ways that reduce inflammation. Should some folks be taking medication for inflammation? I just learned about inflammation on my own because my SED rate was very high. I had a parasite infection, blah, blah, blah. But anyway, my SED rate was very high, way off the charts. Is that something that you all test for in MPN patients?
I would say not necessarily. A lot of times in the process of the workup, people may have had this big workup, which included measures of inflammation, including the SED rate. But I don't necessarily, include it as a standard sort of screener, or I don't necessarily follow it. Exactly how best to sort of clinically follow with blood tests inflammation in MPN is unclear. In research, we can measure inflammatory cytokines in the plasma. To my knowledge, that is not a common, or isn't necessarily available clinically, but potentially in the future, could one incorporate a panel of inflammatory cytokines as a way to measure inflammation in MPN patients and measure response to therapy. In my mind, one of the key benefits of Ruxolitinib or any JAK inhibitor is to reduce inflammation. Interestingly, the other set of diseases where JAK inhibitors are widely used is autoimmune diseases. So it further highlights the common thread between MPNs and other inflammatory diseases, that we use exactly the same types of drugs in both diseases.
Okay. And then to both of you, when you're seeing patients and talking to patients, do you recommend specific diets? You mentioned Mediterranean diet. I'm 100% Mediterranean, pretty much. And we've always eaten a certain way, my family and my parents and so on. Do you recommend diets? Do you recommend other things for your patients when you meet with them? Andrew?
I don't. I go over diet and certainly, reference Angela's work on the Mediterranean diet potentially have anti-inflammatory effects and that while we don't really fully understand the role that plays, I kind of focus on the idea of really decreasing inflammation, on the whole is one, probably never going to be a bad thing, just in general. And at the same time may have some relevance as far as this disease goes, because we know that it is a disease that's kind of spurred by inflammation and then kind of progresses in response to inflammation. And so when we come to the diet, I think, the question that patients often ask, at least recently, is, the role of iron and red meat and spinach and things like that. And I think that's, I've gone down both gamuts with that. Some patients have just completely cut out red meat and spinach and iron containing foods from their diet, despite the fact that that was one of their biggest loves in life before their diagnosis. And that takes a little bit of education, because it's not like iron is the enemy. It certainly, iron will, probably lead to an increased need for phlebotomies in polycythemia vera patients, where it can lead to more red blood cell production. But we're talking about living long-term with these diseases, right? So making someone have a diet that makes them, pretty, if I took red meat away from my wife, I wouldn't necessarily want to live in the same house with her. So, this is the same thing goes for our patients, where we want them to be happy and certainly educate them to say, yeah, there's a role, there's a relationship between iron and the red blood cells, but it doesn't mean you have to fully avoid them.
Okay. And so your thoughts about bone marrow biopsies from both of you. So, typically we get calls sometimes from patients that say, new patients particularly, that will say, I've had, and I am not kidding, 5 to 10 bone marrow biopsies within the last few months, and are just exhausted and scared and freaked out. And possibly their diagnosis was either ET. I mean, any of the three that we focus on, the 3 MPNs. I'll start with you, Andrew, because you're here. What are your thoughts about bone marrow biopsies?
I mean, we're not playing Battleship, so I think you don't really need that many. And these aren't diseases that change that quickly. And so in general, I would recommend a bone marrow biopsy at diagnosis. Unfortunately, some patients don't get it at diagnosis, so it's when they present to see us for the first time. And in many cases, we don't necessarily need a bone marrow biopsy to secure the diagnosis, right? So now we have molecular testing that can give us a JAK2 mutation. We can combine that with the allele fraction, which could be quite low in ET patients, higher in PV patients. We can look at the blood counts and see that they have a hematocrit of 60, right? So that's going to go along with PV. But at the same time, I think what I often will discuss with patients is that, these are progressive diseases that over time can change, and they change at different rates in different people. And what we look for when they're changing is changes in blood counts where they may go down. You may start producing kind of earlier myeloid cells and get this kind of left shift. But at the same time, some fibrosis can be normal, right? Polycythemia vera can present with moderate to marked fibrosis and still be polycythemia vera. It doesn't mean you have true, post-PV or primary myelofibrosis. So having a baseline, knowing what the bone marrow shows initially, can be quite helpful for understanding change over time. At the same time, we've all had cases where we look at a bone marrow biopsy, expect to see something, and then you see a mastocytosis component in there, or you see a hairy cell leukemia that's been sitting in there, or a lymphoid population, or a myeloma. So I think it's helpful to kind of get a full understanding of the disease right off the bat, and then you have all that education moving forward.
Dr. Fleischman, do you have anything to add to that?
No, I don't think so. I mean, I think that I totally agree that I offer a bone marrow biopsy should be done at diagnosis. And I always offer it to a patient. Obviously, it's up to them whether they want it or not. And sometimes if the person's elderly and says, I'm fine sort of not necessarily knowing what my bone marrow looks like, because I'm not really going to do anything about it anyway. I mean, that's perfectly fine with me. And then if there's any clinical changes, say somebody had PV and ET, and I'm concerned that they're moving towards myelofibrosis, or concerned that there's some indication they may be moving towards an AML, then that would be an indication for a bone marrow biopsy. But I don't necessarily just do a bone marrow biopsy after diagnosis just because.
Unless
There's some sort of red flag.
Yeah. And that's what we hear most often as well. Okay, so let's talk about the allele burden for a second. I remember years ago, again, I'm aging myself here, but in 2004 or 5, I had a conversation with a specialist from the Mayo Clinic. And I said, well, does the allele burden have anything to do with symptoms and how people feel? And he said, forget about the allele burden. And now I keep hearing that, the level of the allele burden. So can you explain what the allele burden is and what it means to an MPN patient? Angela?
Okay, so the allele burden, this is not the correct way to say it. It's actually not correct, but it's not the percentage of your cells that have the JAK2 mutation. It's each cell has 2 copies of a JAK2 mutation. So if you mushed up 50 cells, you get 100 copies of JAK2. And then if your allele burden was 50, that means that 50% of those copies had a JAK2 mutation. So a 50% allele burden could mean that 50% of your cells have 2 JAK2 mutant copies, or 100% have 1 JAK2 mutant copy. And PV patients can have some cells that have 1 copy mutated and both copies mutated. This is probably something you didn't want to know, but basically, you can think of it as what percentage of your cells have a JAK2 mutation within reason. That's a reasonable.
I think I actually think that's awesome, because I'll build on that to say, clinically, I think that what Angela is describing is also the problem with the allele burden, right? So, in general, we know that, first of all, I would say for all MPNs, we know a lot of things in general and not a lot of things specifically. But in general, we know that the allele burden, kind of correlates with some disease features. So like the lower the allele burden, the more likely you are to have ET, the higher, more likely to have PV or MF. Higher allele burdens may be more likely to have leukocytosis and splenomegaly, maybe an increased risk of progression to myelofibrosis. But at the same time, that's not by and large true for everyone. And that's probably because there's definitely a lot of detail within that. And so if you're taking 10,000 patients and looking at allele burdens, you can certainly find correlations. But when you're taking the patient in front of you and you're looking at their allele burden, it's really difficult to say exactly what that means. But like Angela said, there's a lot of ways to get to an allele burden. So a 50% allele burden could mean that you have 50 cells that are homozygous for JAK2, or it could mean you have 100 cells that are heterozygous for JAK2, and that's where it gets into the weeds a little bit. And likely, if you were to look at the different kind of symptoms and clinical phenotypes of those people that have varying different ways of getting to the same allele burden, you'd likely see some variations there. And then it gets even more complex than that, because it depends on, where the JAK2 mutation is. Is it in peripheral blood, or, more progenitors?
Yeah, and that, I think that's where the question was going as well, is, what does it mean to me as an ET patient with my allele burden at a certain place in terms of symptoms? And so this is a really interesting question. I am clinically a patient with ET, meaning I only have abnormal platelet counts. I don't meet NCCN guidelines for ET, pyruvate MF, or MF. I have acquired fibrosis, however, in my bone marrow. Any discussion about a new MPN diagnosis? Either one of you?
So is this just an ET patient who has fibrosis in their bone marrow?
Yes.
So as Andrew had said before, that ET or PV patients can have some fibrosis in their bone marrow noted, right, but not necessarily have myelofibrosis.
Yeah, I think it's different for each patient. It depends on how much, right? I have PV patients that have actually marked fibrosis, and they've had that since diagnosis, and maybe they were diagnosed in the early 2000s. And then if you look at their, bone marrow biopsy again, I think we were just doing this the other day with the patient. We looked at their bone marrow biopsy and we were like, "Oh, you have marked fibrosis in there." But then we got a hold of their bone marrow biopsy from 2004, and it also had marked fibrosis, and their clinical phenotype was the same. And that's why we have actual criteria to define whether someone has post-PV myelofibrosis. And a lot of that determines whether you're getting, additional features of the disease, anemia, splenomegaly, progressive constitutional symptoms have to go along with that. It's not just fibrosis. And so, for that patient who has ET with the fibrosis, you'd be looking at other factors, other features of the disease to suggest that is this transforming or is this really just an ET with fibrosis?
How common is it to have CLL along with an MPN?
Well, if you're going to pick another leukemia, that's probably the most common one to have. So that is CLL is the most common, leukemia in the world, and it's not really, maybe there's some component that's shared between the two, but I would look at them as largely separate diagnoses. You have a chronic lymphocytic leukemia, and then you have a chronic myeloid leukemia in the form of the MPN. So I know I have probably 10 patients that have combined CLL. I have patients that have combined myeloma, which is also quite common with their MPN. So we do often see these dual hematologic malignancies.
Angela, do you have anything to add to that?
Yeah, no, I have multiple patients who have MPN along with a lymphoid malignancy.
Fatigue, as we know, is a common symptom with our MPN patients. How do your ferritin levels correlate with this symptom?
I don't know if I've seen a direct correlation with ferritin levels. I mean, we know ferritin's an acute phase reactant, so in inflammation, ferritins can go up, but also with MPNs, especially JAK2 mutant MPNs, ferritins are quite low because we use up our iron stores. I don't think there's because of that, I think it's really hard to get any direct correlation between one or the other. And I'm not even, to that point, I always try to understand where the question is trying to lead me to, and I'm not sure which direction. Are we looking to say that the elevated or lower ferritin levels would be associated with that?
Well, what can mitigate, or how does one lower their ferritin level? Is taking iron presents other challenges. Any suggestions?
Well, with iron deficiency, ferritin goes down. So somebody who's iron deficient, the ferritin is down. So it's more like also a marker of iron stores in a person's body.
Correct. Yeah. So in PV, we're looking at this with we know that there's probably some symptoms that go along with the iron deficiency that comes with the disease, and then we worsen with phlebotomies. And so actively, we're looking at agents that can potentially minimize the need for phlebotomies, but control the hematocrit, and maybe that could effectively restore ferritin levels or normalize iron levels, and see if that is associated with any kind of symptom improvement. That's kind of the ongoing thought process behind the Rusfertide PTG 300 study. We've enrolled patients to that study, and certainly have had some that believe that their symptoms have drastically improved since being on it. At the same time, I think there's a component for just not having to come in all the time for phlebotomies, which is not something that correlates with a good quality of life.
So I'm sure that both of you have seen the number of younger patients being diagnosed, proliferate on its own. We certainly have. And so this question, I like this question quite a bit. I think it's very important. I've been recently diagnosed with essential thrombocythemia. I am a 42-year-old male. I read in multiple sources that life expectancy for ET patients is almost as normal. However, I also read that prognosis worsens with time since diagnosis, and that mean age at diagnosis is around 60. Hence my question, does the statement life expectancy almost as normal hold for younger patients as well?
I think that it's a tough question. I think whenever we look, there's probably 5 or 6 publications specifically in MF looking at younger patients all the time. Every time it says that our prognostic scoring systems are not really relevant to the younger group, they do better. But they probably don't do, at the same time, they probably don't do as well compared to a normal life expectancy as maybe our older patients do, because they have a longer time, potential time to live. I think there's going to be data coming out relatively soon that may look into this specific question with a little bit more, a little more specificity. My general thought process is probably, it's probably hard to answer for an individual patient. I'm going to just keep throwing that statement out, but certainly these are progressive and chronic diseases that over time change. If you get diagnosed younger, it's likely to present challenges going forward, but everyone's going to be different in how they progress. And it's why we have to kind of monitor these diseases, and why Angela needs to keep working in the lab so we can prevent them from progressing.
And another issue could be earlier diagnosis. We do know now that actually there are two separate studies looking at basically when somebody acquired their JAK2 mutation, and it was clearly decades, 20 to 30 years prior to diagnosis. So even though somebody may be diagnosed at age 60, they clearly had their JAK2 mutant cells for decades prior. So maybe, the person who's diagnosed at 60 really did have ET at 40. So there may be also this sort of lead in time for diagnostic bias that maybe some people are just diagnosed earlier than others.
So Angela, and we have this discussion quite a bit and have over the years about the heterogeneity of these diseases. One person does very well throughout their life and lives a very long and productive life with an MPN. So, it really is so specifically yours. And but another question, Angela, can you share your thoughts on the use of ropeg in patients with essential thrombocythemia or interferon?
So interferon, which most people these days in the US use, currently Pegasus is approved. Ropeg interferon may be approved shortly in the United States. So let's just talk about it like interferon in general. Interferon is a very special agent in MPNs in that it has the unique ability to, in some people, lead to a molecular remission, I guess you could say, where their JAK2 mutant cells are no longer detectable. So it's probably the agent with the most data to support that it may be a disease-modifying agent. And likely when and if ropeg interferon is approved in MPNs, it may increase in enthusiasm, and there may be an increased percentage of early stage MPN patients who are on ropeg interferon and potentially change disease trajectory. I'm probably not answering your question.
No, you actually are, because I think you bring up another question, and that is, the drugs that address the constitutional symptoms versus the molecular symptoms. And so, we know from many studies that interferon does tend to address the molecular and then the constitutional. Would you agree with that? So,
yes, and I have to say, in terms of my patient population, people are usually quite I don't say scared, but they've read about the side effects of interferon. But what I've been struck with is how minimal the side effects really are, and how many people tell me, oh my God, I feel so much better. There's just something different. I just feel back to normal now. And they were sort of expecting to have bad side effects, but instead they feel so much better. And I've just been struck by that.
Yeah, and the area I've been struck by, we sent a survey out to women, particularly just asking general questions about their symptoms and so on. And one of the things we heard were migraines, but from the women that were on interferon, their migraines went away, which is ironic, because some people on interferon get migraines, so, or get bad headaches. So it was really interesting. We got a question, and I feel bad about this because we are in meetings all the time and hearing initials, not acronyms so much, but initials. And so I said SED rate, somebody said, what's SED rate? And so sedimentation rate, would you mind explaining that, Angela?
So it's just a measure of, I have to say that I may be saying this wrong, of how long it takes the when you put the blood to sort of go down, and it's a marker of inflammation.
Of inflammation, yeah. And I mentioned it because I just had that blood test a couple months ago. And as I mentioned, my sedimentation rate was really off the chain. And I did have a inflammation and had an infection, a parasite. So that's what caused it to go up. So the other question was CLL, isn't that chronic lymphatic leukemia?
Correct.
Yeah.
Chronic lymphocytic leukemia.
Lymphocytic. Okay.
Basically too many lymphocytes in your blood.
Yes. Okay, so I'm going to try, since Andrew is with somebody at the moment, I want to talk to you more about familial, your study, if you could elaborate on that, because I have a question here. I have PV, as did my grandfather's brother, and my mother's cousin. Clearly some family connection. I am 6 years into my diagnosis, taking baby aspirin and occasional phlebotomies. Should I be doing more to prevent progression to MF?
So I think there's probably two questions there. Number one, the familial, and I'm not sure whether the person is trying to insinuate because they have a familial history of MPN, are they more likely to progress to MPN? I think the second question is no. And a question that I've always been asking is, say your parent had MPN and then they developed myelofibrosis and AML, are you more likely to sort of have the same fate as your other family members? And looking in the literature, that, we don't have a lot of data, but that does not seem to be the case. However, there's really honestly no data to sort of back that up. The first question was the familial predisposition. Yes, there's clearly a familial predisposition. Exactly what that is, we don't necessarily know, and that's something that my lab's trying to figure out. And what we're also trying to investigate is whether unaffected family members, they may not have a clinical MPN, but could they have very small numbers of JAK2 or paraticulin mutant cells in their blood, but not have any signs of an MPN.
So this person could be a very good person, and that's
correct. Yes.
Yeah.
So
we'll make sure we'll connect you to.
Okay.
And it's interesting because my mother had Mediterranean anemia. All three of us girls, the girls in the family have it, and my brothers do not. 4 brothers do not. So it's just interesting how things get passed around. Okay. Hello, Andrew. You're back. What is the difference between ET and pre-fibrotic myelofibrosis? I was told I had ET and now am being told I have PV/MF. Andrew?
Well, I'm liking in Angela's screen, occasionally a dog showing up, but occasionally it's not. It's decided that that's a living thing. So going through ET and pre-fibrotic myelofibrosis, I think that, this is kind of an attempt for us to be a little bit more specific in our diagnoses. I think for a long time, ET patients, some progress to myelofibrosis, some don't, some do it faster, some don't. And the way we currently defined things, at least for the WHO criteria, it was really hard to kind of ferret out that group of ET patients that I think people knew. You had this feeling that those were the ones that were going to progress. They looked like they had a different disease, but based on our criteria, we couldn't really say that they had myelofibrosis. And so this was an attempt to really kind of siphon off this group of patients that were very likely to progress to myelofibrosis, that really had cellular morphology that looked more like that from the ET patients. And so there was some work done in kind of the late 2000s, early 2010s that was really trying to show that these were distinct groups of patients. And so that's where it really comes from. With ET, when we're looking at the bone marrow, we're seeing megakaryocyte hyperplasia. We're seeing a normocellular bone marrow, meaning a kind of a normal ratio of blood cells to fat or adipose cells in the bone marrow. And so you're typically seeing, you're just seeing enlargement of these megakaryocytes, which are the platelet producing cells. And usually ET patients have a very slow progression to their disease. Most do not progress to myelofibrosis over the course of 10 years, but maybe more so over the course of 10 to 20. But then pre-fibrotic myelofibrosis essentially looks like myelofibrosis as far as the megakaryocyte morphology. So you're seeing megakaryocyte atypia, you're seeing a hypercellular bone marrow. You may be seeing more clinical signs and features that we see with myelofibrosis, like anemia, increased LDH. So this is clearly a more active disease, but they just lack that fibrosis, right? So now you're just having either minimal or no fibrosis. So I think that's really the big caveat there, is that pre-fibrotic myelofibrosis is really just kind of an early non-fibrotic form of a disease that we otherwise characterized as such, and it just we knew these patients were different at the beginning. Now we just figured out a way to classify them as such.
Do you have anything to add, Angela?
No, I think that was a very, very extensive answer there.
I was going to say, you might see bats flying around my house.
I'm sorry, my dogs are fighting.
Instead of your, no,
they're going outside now. So
I'm teasing. My neighbor just got a bat in her house, so I'm kind of or aware. Okay, so is PV always progressive? This is a great question because, a lot of our patients, I know a man who is 94, who's had PV since God knows when, 60 years, I think. And I met him when I first started working at the MPN Research Foundation. And I mean, so can either of you share whatever your belief is on the subject?
That's a good question. I mean, possibly sort of the inevitable consequence is always to progress to myelofibrosis, but could the time period be in that guy maybe 100 years? We don't know,
Yeah.
But clearly some people progress faster than others. And some people never progress in their natural lifespan.
Yeah, I think the mathematical modeling papers that deal with disease progression, just from our understanding, are very interesting to that sense. I mean, clearly these are theoretical papers that take into our understanding of cell cycling and cell turnover and the role of inflammation. And it requires a lot of assumptions when you do these modeling, but it just shows that if inflammation is going to select for that PV clone, that JAK2 clone, that stem cell, that first mutation, the progression is going to naturally happen over time. But if this is the interesting thing about inflammation, where I get very interested in watching people's, Angela's work and others, where if there was an inflammatory insult that you're aware of that kind of led to the initial emergence of this JAK2 clone, but then you're able to remove that inflammatory insult, what does that do to the disease? Is the cat out of the bag at that point? Are we able to put a little bit of the cat back in the bag? I don't know. And so, I think that we do have patients that I have a patient diagnosed with myelofibrosis in the early 80s. And the disease just really hasn't changed over time, significantly for that patient. That's clearly the exception, right? That's not common, but there's something interesting about whatever caused his disease to be diagnosed that early and why it hasn't changed that much over time.
It is fascinating. Okay, so with the current treatments for MPN patients, including hydroxyurea, and what is the potential for patients that are on, I'm using this as an example, HU, for solid tumor cancer, for getting a solid tumor cancer from the use of HU? Angela?
So MPN patients do have an increased risk of, maybe that's not the correct terminology, that they do tend to have more solid tumors than somebody without an MPN. So it'd be a little more difficult to tease out what's the effect of sort of their underlying risk of having an MPN versus hydroxyurea. For hydroxyurea, as well as JAK inhibitors, there is a clear risk of increase of skin cancer. There's always the concern about hydroxyurea and increasing one's risk of leukemia, there's a concern, but not necessarily been definitively proven. For solid tumors, I have to say, I don't know the answer to that. Andrew, do you know if there's been any studies looking at hydroxyurea use in solid tumors? I have to imagine, because hydroxyurea is also used in sickle cell anemia, maybe in that population, there's been some studies.
Yeah, I'm not. I think that certainly the non-melanoma skin cancers is the link that I'm aware of. As far as solid tumors, otherwise, I don't think there's a link that I know of that links hydroxyurea like directly to that. I mean, we do use hydroxyurea, or have in the past used it in the treatment of solid tumors, and certainly as a radiosensitizer as well. But no, I mean, that's not something that I agree with Angela. I would kind of link the MPN itself to the increased risk of secondary cancers than I would link the hydroxyurea.
All right, so this is a great question in my mind's eye. How does one know if PV is in the early stages of the disease? Andrew, we'll just start with you, right?
Yeah, I mean, I think it depends on how you define early stages, I guess. I mean, I think that ultimately, if it's the first time you've been diagnosed, it's in the early stages. I think when you don't see a lot of, I think it's probably a misnomer to link fibrosis and early. There's not, unfortunately, we can't look at the bones and count the rings and see how long you've had polycythemia vera. But I think that, typically, I don't know, and it's just a tough way to frame it. I think that's a hard, like whether or not we're talking about early or late stage. I think when we're talking about later stage myelofibrosis or polycythemia vera, we're typically talking about spent phase where you're starting to get more post polycythemia vera myelofibrosis. But PV in its early phases is usually proliferative, leads to a diagnosis. It's not something that often presents in the late stage, I guess.
So for Angela, since you have to leave in about 10 minutes or 7 minutes here, I'm an identical twin, and we both have polycythemia vera. I am joining a familial study at Johns Hopkins with Dr. Evan Braunstein. Is that the same study you're doing?
It is not, but I'm actually really interested in identical twins. I have a number of identical twins, one with, actually, I don't have any sets, one with PV and one with not. So I would really love to get a hold of you guys. I just want to make sure that it's not that you have actual PV with a JAK2 mutation and not like a familial. I mean, either way, you're interesting, but but it's.
We'll make sure that this person gets a hold of you. We'll make sure that this person gets in touch with you.
Okay. Can she be in 2 studies?
Yeah, you can. Why not? You can be as many studies as you want.
Hey,
perfect. Okay,
that's great. That is great. And so I thought I had another one here for you, Angela. I'm bouncing around here, so pardon me. Okay, I heard or read that blood cancers are developed with the influence of inflammation. We just kind of talked about this already at a cellular level and continue during the disease. The cellular level inflammation creates the characteristic symptoms of MPNs. Can you confirm or refute this concept?
Well, I confirm it. I'm not quite sure what cellular level means because inflammatory proteins or inflammatory cytokines are produced by cells. So, so I agree. Inflammation is at the cellular level. So I agree with that.
Okay. What iron levels, when you're looking at your patients, what iron levels concern you?
Could the person be talking about if they have myelofibrosis and they need transfusions and then their ferritin's going up?
This is just the question. That was just the question. I guess I would just address it however.
Okay. Like. In terms of the ferritin with transfusions, that is a big potential issue with chronic transfusions, that it'll give you iron overload and then the ferritin will go up. In general, like if the ferritin goes around 1,000 or so, then one may need to start to take some iron chelation pills to try to get rid of the ferritin or to get rid of the iron. But maybe that's what the person's asking.
And do either of you, I mean, when you are with your patients and let's say you have a bone marrow biopsy report and you have a blood, all their blood work is in front of you, Do either of you ever show the slides to your patients and explain to them what's happening? And, instead of saying you have this and this is what our typical treatment is, and these are the groups you can contact for support, and, here are the resources. How do you approach a patient that has, let's say, the initial introduction to the disease, and then let's say it has changed 5 years down the road or 2 years down the road? Angela, I'll let you go first.
So I think your first part of the question was, do we actually look at the slides with the patient? I think these days, like I remember when I was in medical school and like going to hematology clinic, there would be a microscope like in the doctor's workroom that we would actually physically look at the slides. At the present time, I mean, at least in my clinic, we don't have a microscope sitting right there, nor would I necessarily have access to the actual glass slides for the bone marrow biopsy. But what I do is, with the report, sort of go line by line what things mean. They say hypercellular marrow, they say tri-lineage hematopoiesis, increased megakaryocyte. So like line by line, talking about what each sentence means. And then if somebody had 2 bone marrow biopsies, say, hey, look, in 2000, this is what you look like. And now in 2021, now it's changed this way.
Okay. Andrew?
Yeah, similar things. I mean, I think that going through the bone marrow biopsy is trying to explain, because like now with people having access to their bone marrow reports and records, it's that's like me having access to a Russian dictionary. It's not really that helpful. And so I think that patients can get a little bit bogged down in some of the wording that's in there, and then try to Google those words to try to figure it out, and then you run into all sorts of problems. So going through and kind of explaining why the phrasing is used there is helpful. I think one thing that's often used that runs into problems is people say, well, I have megakaryocyte atypia, that means I have myelofibrosis, and often the pathologist will be saying that they have atypical megakaryocyte hyperplasia, which is more consistent with ET. And so that's kind of an example of things that can get, I could understand why there would be confusion there. I'm not above also Googling, if someone is interested in what their bone marrow looks like, I'm not above like Googling representative pictures of what an ET marrow looks like compared to a PV, compared to a myelofibrosis. And certainly we do have some patients that are quite interested in looking at things like that.
Okay. So Angela, you have 2 minutes, I'm only going on your time that you have to leave. So what would you like to share with the patients and caregivers and other groups that are watching right now, that for the future? What do you see in the future for MPN patients?
Well, I think that that MPN patients should be empowered to take sort of charge of the direction of their health, and that early on in diagnosis, I think that life's basically doing all you can to be as proactive with improving your general health will improve your disease trajectory. I know there's a lot of focus on medications and things like that, but I think we underestimate what we can do for ourselves in terms of optimizing our own health. With regard to the diet, I honestly don't think that it's something specific in specific foods, but by incorporating a general healthy diet, it makes people focus more on their general health. Mm-hmm. So what I'm trying to communicate is disease trajectory is in the patient's hands to try to optimize their health as much as possible.
Mm-hmm. Mm-hmm. I would agree wholeheartedly. And thank you so very, very much for joining us today. I know it was a little early for you, and we will be in touch. And I love the fact that you're doing this study, and we will send as many people your way as possible. And thank you again.
Thank you so much, everybody. I will see you later. And nice to see you again, Andrew. Okay, bye.
Thank you. Bye. So Andrew, we have a gazillion questions. Do your kids say that? We have a gazillion questions.
They just say 40. That just means a gazillion if it's 40.
40?
Yeah.
Okay, I also read there is an influence on stem cells from the bone in or around the bone marrow that creates and maintains the cancer stem cells. How come MPNs are never cured?
Yeah, great. Oh, real benign question to start off with. Like,
Yeah,
cure these
benign
things,
is a
right?
good word.
Yeah. Yes, obviously all of our cells have stem cells. The stem cells are the cells that are responsible for kind of leading to all these different cells, and stem cells are there always, and they cycle occasionally. And what you're referring to is there's these the mutations occur, like JAK2 mutations, CALR, MIPL. These occur in the hematopoietic stem cells and ultimately lead to the blood cells being produced that have these mutations in them. And there's this positive feedback loop that occurs where once there's one stem cell that has a mutation, that stem cell that has a JAK2 mutation creates inflammation from activating this JAK-STAT pathway, and the inflammation that occurs then actually fosters progression and promotes the survival of this MPN stem cell. And we are starting to understand a little bit more of the dynamics at the bone marrow level. There's probably this niche that's involved, and there's been good studies looking at the role of specific cytokines and mesenchymal stem cells and neuropathy that's induced by different things. So it's very complicated to understand really what's allowing those stem cells to survive, what's allowing them to kind of outgrow at the expense of our normal stem cells. And honestly, if we could figure that out, if we could get to the core of what is propping up these mutant stem cells, then we would really get to something that might be more disease modifying. And honestly, I would say that the science that's understanding that has really skyrocketed in the past 5 years. So, I think that we can start having meaningful, efforts to do that in the coming years.
So we would be remiss if we didn't address some of the COVID questions. And, we, over the last year and a half, we've talked a lot. In fact, you were with us on another program where we talked about the importance of getting the vaccine. And now, of course, we're coming upon booster shots, which I will be getting mine Sunday. And so can we talk about the vaccines and how Jakafi has shown to interfere with the vaccines? Also, will data be out for MPN patients receiving the third shot or the booster shot and antibodies being increased? Can you talk about that at all?
Yeah, I mean, we certainly don't have all the information. I think that generally speaking, what we know is one, MPN patients who get COVID are at high risk for adverse effects happening. I think the early Italian data was pretty severe in that sense, and probably overstated that fact a bit. But that was also a terrible situation that Italy was in, really being at the forefront of this pandemic and really not having the educational resources and the understanding that we necessarily had when the pandemic hit the United States. MPN patients can respond and certainly fight COVID infections. The only thing we really know about the treatments that patients are on and their response to that is that we should not discontinue Jakafi in the middle while we're getting a COVID infection. That's been shown to have pretty dire effects if you discontinue Jakafi in the midst of a COVID infection. We really don't know too much about the role, positive or negative, of things like hydroxyurea or interferon in the middle of that. I have not been discontinuing my patients if they have COVID infections because I think that a lot of times these medications are there to create some sort of equilibrium and balance, and I think perturbing that by discontinuing a medication that patients are stable on is probably going to be more likely to do harm than good. In regards to the vaccine, I think the early data just showed whether you had antibody response or not, right? It was a yes or no question. And we know that most patients with MPNs, regardless of what they're on, most of them were having antibody responses. 95, 96% were having antibody responses to the vaccine. And the more recent studies that have looked about the level of the antibody production or potentially the T cell responses, it seems like it may be blunted a little bit in patients that are taking Jakafi, which isn't that surprising. Given the fact that Jakafi is, acting on the JAK-STAT pathway, it does have it does impact T cell function, And so it's likely to blunt it somewhat. It wasn't negating it, it was just blunting it. And so that's why we thought a third dose might be quite reasonable in that patient population. And now obviously it's coming out that third doses are reasonable in several different immunocompromised groups of patients, and Jakafi would be no different than that. And then booster shots are going to be similar, just given at a later date than the third dose. So I'm a big proponent of getting the vaccine. I think if you're on Jakafi Hydrea, maybe not interferon, then getting a third dose is quite reasonable. Most of our patients are elderly, so they fall into the categories of recommending that as well. And then booster shots, I think, are a little bit more debatable in what they do. I definitely proponent of a booster shot. I think it's likely to give you antibody responses and likely prevent you from getting symptomatic infections. I think you still do have immunity from the original vaccines, but there's likely to be T cell mediated immunity, which means that it's going to be more effective in preventing severe infections rather than just the basic symptomatic infection.
And so, this person, and this was a question that came up earlier that I forgot to ask, I apologize, but, there's a lot of discussion out there in the physician and researchers community about, when to treat a patient with an MPN. So this person is a 52-year-old female. She was diagnosed 8 years ago, CALR type 2, and no history of depression symptoms, somewhat fatigue, dizzy once in a while, hand numbness often. She does have hyperthyroidism and takes Synthroid for that. But her question is, do I continue to watch and wait, or do I consider interferon at this point?
Yeah, I mean, I think it's a tough question. I don't think there's a right answer to that. I think, there's a few caveats there that I would look at. And, I'm a proponent of, I think it's more about putting all the information out there and having a shared decision with the patient. We certainly have our absolute indications for putting people on cytoreductive therapy, prior thrombosis, older than 60, JAK2 mutation, high risk features, right? Those would be reasons we definitely want to put people on cytoreductive therapy. But then there's this kind of minority of patients where we don't, and that's where the question rises, right? If we don't have an absolute indication, patients that are younger than 60, no prior thrombosis, maybe they have a CALR mutation, maybe they don't, that's where we have to really think about, what are our goals of therapy? So in a type 2 CALR mutation with no history of thrombosis who's in their 50s, the question is, what are we going to accomplish by doing interferon? Some would say that interferon has the potential to impair disease progression. And maybe it does. I think the data is really challenging to interpret because we're getting kind of really broad data sets coming from single or multiple institutions, whereby there's the high risk for selection bias of the patients that were treated with interferon versus those that were not. And so it's really difficult to parse through that and really say anything definitively. The other thing is we know that interferon is probably more effective in JAK2 mutated patients as far as the role that it has. So really, what is it, does it still have, if it has disease modifying potential in JAK2, is it less disease modified? Is it none? We don't know that. And it doesn't come without potential side effects too. So, there's certainly that needs to be taken into consideration. So honestly, I think this is why our initial discussions take so long in the clinic, is because we really don't know a lot of these answers very firmly. And when you get these gray area cases, we have to go through each potential cytoreductive agent, what each agent will do benefit-wise, what it will do potentially side effect-wise, the rationale for doing it, and then really kind of, once we've explained all that, really get into the details of if this makes sense for the patient. So that's a bit of a hedge, but honestly, I'm hedging that way with every patient. We're going through those details. There's no right answer there.
And what are the latest results using interferon and Jakafi? We've talked a lot in the past about cocktails. Because there are so many new drugs in the pipeline right now, and what is working for some, and also the use of Jakafi prior to stem cell transplant. Can you address that?
Yeah, so combination of Rux and interferon makes a lot of sense for a variety of reasons. It's been looked at already in Europe. That study is a little bit difficult to know what to do. It looks like it's safe to combine. The two can be given together. The response rates are quite good, but the response rates in PV are quite good with whatever you're using, if you're just measuring on a complete hematologic criteria. And so, I think that right now we don't have the data to suggest that it's better than a single agent by itself, but there's certainly patients where we need something extra. And I think that the rationale behind it makes sense. You have Rux, which doesn't do a ton for disease progression, but certainly can control symptoms of the disease. And then you have interferon that may not be very good for symptoms, but might help disease progression over time. It's potentially also an expensive cocktail, which is not to be underappreciated, because Rux is $16,000 or so a month, right? But obviously different for what patients pay. And then interferon is, I think there was a question in the Q&A session about how interferon is considered to be off-label, which it is technically. So is hydroxyurea, because these are older medications that we didn't go through the same registrational process that we went through with ruxolitinib. And so insurers will often say, oh, it's off-label, I'm not going to cover it. And then you have to do some paperwork to show them that it's recommended as a first-line agent. But yeah, so I think that all we know about Rux and PEG together is that it's safe. And in whether or not there's a benefit to the combination over a single agent, it's TBD. It's pretty much theoretical right now. That being said, we have a few patients that are on the combination. As far as Rux prior to transplant, I think multiple studies have shown that it's safe. There's no clear-cut winner as far as when the right time to discontinue Rux if you're taking it into transplant. We know patients with smaller spleens do better with transplant. Therefore, Rux is what gets the spleens down. So continue that right up till transplant. We have some groups, including our transplant group, will continue Rux into the transplant and try to discontinue by day 30. Now Rux is emerging and just got approved as a GVH medication as well. Certainly not frontline for that, but it may have a role there as well. But it also causes immune suppression to some degree, right? To a milder degree. So maybe it's not the best thing, but we know that it's safe to take up till transplant. It's likely safe in the early stages of transplant as well. After that, a little bit TBD.
And GVH, for those of you that don't know, is graft versus host disease, and which I think everybody gets when they have a transplant, correct? Can you explain that a little bit?
Yeah, so graft versus host is essentially if you're taking, we do allogeneic stem cell transplants for myelofibrosis. We don't really offer them for PV or ET, mainly because the prognosis of PV and ET are too good to consider a treatment that has a 10 to 20% chance of dying within a year of a transplant, right? So that's not the coin flip you want to take if you have a relatively good prognosis of your PV or ET. But we do allogeneic transplants, which means we take your own immune system away, your immune system, your stem cells, your blood stem cells, or what have the disease. So we take them away and we give you someone else's blood stem cells. And when that happens, we take your immune system away, replace with a new one. So there's a lot of risk for infections. But there's still some of your disease. We can't get rid of all your disease with the chemotherapy. So we rely on the new stem cells to actually fight and kill off your old disease. So there's something called a graft versus leukemia effect, which is the T cells that you're getting from your donor that are really kind of wiping out the rest of your mutant cells. And what we've done to get you ready for that, what the conditioning regimen is, which is giving chemotherapy prior to that, is really to kind of unlevel the playing field so that the donor cells have a better chance of winning that fight and taking over and really becoming the new dominant bone marrow or stem cells. Now, graft versus host disease is where those same T cells from the donor then start to attack your own organs, right? And they see them as not being self, and they attack those, and it can lead to various different GI effects, skin, liver, eyes, things like that. And that's why it's such a tentative time after transplant. You're on a lot of immune suppression medications to try to prevent that from happening, but at the same time, you don't want to be on too much immune suppression because you want that new graft to take hold.
So 2 questions, and boy, we're getting really close to time already, but
I'll be quick on each one of these. Yeah.
Oh, that's okay. Because our patients love to know this and should know this, but one is, when do you determine whether your patient is a candidate for a stem cell transplant?
Yeah, so first visit, and then continually throughout. So we have prognostic models, multiple of them, that really the goal of those models is to figure out in this setting, is this survival of this disease less than 5 years or more than 5 years? And certainly that's not individualized. We're doing that broadly, but if the survival is expected to be less than 5 years, then typically we're recommending at least an evaluation for transplant.
So what if I'm a young patient and I'm doing very well, and you are my physician, my hematologist, and I say, I really would like to do this. And I know you have to have myelofibrosis, correct? To be able to
Yes.
have a stem cell transplant. But this is a question we're getting more often from PV patients, and that are really interested in a stem cell transplant. What are your thoughts on that?
Yeah, so I think that is a challenge. There are certainly young patients that have PVET, quite problematic, and they want to consider doing a stem cell transplant. I'm not saying that's off the table. I think that we haven't done it, but I certainly could come up with a theoretical situation where that might be a consideration. It would have to be quite a young person with really, really debilitating disease that has been through all treatments that we think would make things better, and really not yielded the benefit. And in that case, I think that it would really take sitting down with the patient, the transplanter, making sure all treatments were exhausted, probably getting a second opinion from another MPN specialist, because that's going against the grain of what we typically would do, and making sure that this is really, and the risks are completely understood. But yes, usually, it's something that's reserved for myelofibrosis patients, but I never say never.
So, we do have some questions here about, and we've talked about this at our organization about, how does a physician, if you have a patient that does not have great insurance, does not have, the financial wherewithal to afford some of the drugs that are available to them, how do you as the physician tell them to, I want you to take this? And I mean, is that a discussion you have with them? Do you know in advance what their insurance will cover? Or how do you address that? I've always wondered, we've talked to a lot of doctors about this, because, sometimes the patient ends up with not the best treatment for themselves, for their diseases, because they can't afford the best.
Yeah, so I would say the first thing I do is I completely don't think about cost at all initially. So initially, I think my job is to look at the patient, take everything into account, and say, based on everything you're telling me, based on this is what I would recommend. And then it's after that we need to think about cost. And so typically what we will do, and when we're talking about PV and ET, we're usually talking about interferon, hydrea, ruxolitinib. When we're talking about MF, it's going to be ruxolitinib, fedratinib, and certainly some of those interferon, rux, fedratinib have cost issues, real cost issues, but they're unpredictable, and I certainly have no idea who's going to run into those issues and who's not, and I don't know what people's financial situations is, and even if they're make $1 million a year and have a good financial situation, it still doesn't mean that they want to spend $16,000 a month on a medication. So first off, I say, okay, this is what I think is the right medication for you. And I say, we're gonna go through the process of trying to get you this medication. And what that typically means from my standpoint, and it's different, what makes it even harder for you when you're trying to counsel patients from different places, is that it's different in every state, every institution and stuff. So we'll send it to our specialty pharmacy, and let's say ruxolitinib or fedratinib. We'll send that to our specialty pharmacy, and the specialty pharmacy will talk to the patient's insurance company and say, a prior auth is needed. We have a prior auth department at Moffitt that will work on getting the prior auth, and they will ultimately, usually it's indicated, right? So then they'll authorize it. It doesn't mean they're going to pay for it or cover it. And then we tell patients, before you pick up the medication, before you pay anything, I want you to call us if it's more than you're willing to pay, or if it just seems high to you. If obviously someone calls you and says it's going to be a $0 copay, well, then just run down there and pick it up and don't ask any questions. But if someone says it's going to be $800 a month or $400 a month or whatever is inappropriate, just call us. And then my nurse is fantastic at working with our specialty pharmacy to look for resources, Leukemia Lymphoma Society, through Insight Cares program, different company sponsored programs, to see what else is out there. And we go through all of those different things. And ultimately, we still have some patients where it's too high of a price. And then that's when we sit down and say, all right, here's what I think this medication would have done for you. Okay. The next best option is this. And here's what I think this medication will do for you. And sometimes there's a small gap and sometimes there's a big gap. And I think that matters in determining whether or not it's something that people want to pay for or not. So I don't know. It's a challenge.
It is a challenge. And you mentioned two organizations, and most companies will have something in place, and Insight does with Insight Cares, and others have something in place. And then we also have a few other resources. I just want to make sure the patients know that if they are looking at taking certain or trying certain treatments and are afraid of what might, what the stumbling blocks might be financially, just let your physician know and let us know, and we can possibly send you to the correct place in person. One more question, and then I'm going to ask you to wrap up and just, share whatever you'd like with this audience. Some hope. So, I'm pretty hopeful. We've got tons of new treatments in the pipeline. But before that, discuss natural immunity. I have ET and had COVID. I was not hospitalized, but did get double pneumonia. My antibodies were 1,798. The risk benefits scenario, do I need a vaccine?
Yeah, so what we've seen with natural immunity, certainly it's better than no immunity. But across the board, natural immunity is somewhat variable. And so patients, when you get a COVID infection, can either be exposed to a lot, a little. The immune response can be robust, it can be mild. And so while natural immunity on the whole seems pretty effective, it's pretty variable. And so it's not very consistent. Now, when we look at responses, some natural immunity seems to be even better than the vaccine to some degree, but we can't predict which patients are going to have it be better than the other. And when we see together, the combination of the vaccine plus natural immunity is really where we see the best protection. So I've always advised patients to even if they've had a COVID infection, and this is not just patients, it's colleagues as well that have had COVID infections, everyone's going in and getting the vaccine as well. I think that the data supporting the vaccine is so strong, and the ramifications of not being protected are so clear at this point, that I couldn't more strongly, whether or not you've had the COVID infection or not, recommend getting it. Now, there is some time frame windows that people have talked about, maybe 90 days or so. I think that differs. I don't think we really know the greatest answer to that, but even if you've had the COVID infection, I think to really know that you're protected, and to really be able to interact with patients that don't have the ability to respond to the vaccine or don't have the ability to get the vaccine. Like a lot of our patients we see at Moffitt who are on chemo that aren't going to get it. I think if I had gotten a COVID infection, I wouldn't have relied on that to feel like I was safe around leukemic patients. So couldn't more strongly recommend getting the vaccine as well.
So before we close, again, I just want to say thank you to you very much. I know it takes a chunk of time out of your day and your work. What are your thoughts? We are extremely optimistic from where we sit. What are your thoughts about the drugs in clinical trials, the 3 drugs it looks like that are 3 treatment options that may be approved in 2022, possibly? What are your thoughts on those and others?
This is an exciting time, frankly, for MPNs. I think that there's a natural progression to progress within the oncology space. We start with, finding out, first of all, defining the disease. Then you find out some biological underpinnings from that. Then you identify the pathways and pathophysiology that's really core to the disease. Then you start to get into the details of what can best target those pathways. Unfortunately, that process takes 20 years. And we started with finding the JAK2 mutation in 2005, really defining these as true malignancies in 2001. So now we're 20 years after they were defined as true malignancies, and maybe that was certainly a delayed state or process anyways. But now we're starting to see the fruit of that labor. Ruxolitinib was certainly a game changer, but it's not everything. It's a very good drug for a lot of people, but it's also not appropriate for many and insufficient for others. I think that the field is certainly moving in a direction where we're going to get some answers. We're focused on the late stage of the disease, but we also are increasingly focusing our attention on preventing progression and non-toxic, efforts to see if we can modify some of the more challenging symptoms from this disease. And so I feel like we're attacking this from all different aspects. I think we have a great core of researchers across the US and internationally. We work really well together. There's a lot of collaboration. We have great patient advocates, patient advocacy groups, research foundations, basic scientists, clinical researchers, young, old, mentorship. I think that just the entire environment within this field is massively conducive to coming up with progress. And then, probably maybe the most important thing is we have patients that are so focused on understanding their disease and being a driving force behind the momentum that's being made, that it's hard. You look at the success of like the Susan Komen Foundation or with breast cancer, it's patients that drive this. It's patient volunteers on trials, it's patients supporting advocacy groups, it's patients that are lobbying the FDA, it's patients that drive all of this. And it's us as researchers that are happy to move forward, but really we can't do it without the participation of patients.
I would agree 1,000%. I mean, I've never worked in such a invigorating, loving, supportive environment in a disease area. I mean, it's just been phenomenal, and internationally, absolutely. And so I'd like to thank you again for joining us. I know you have some things to tend to today, and we will call on you again. And for all the patients and caregivers that have sent this wonderful list of questions, we will continue to do these programs so we can continue to answer those questions. I'm sorry for those that I was not able to answer today. I do want to thank wholeheartedly our sponsors, because we would never be able to do these without them. Insight Corporation, Imago Biosciences, CTI Biopharma, Pharmacentia, Sierra, Cartos Therapeutics, Protagonist, Avi, Geron, Acceleron, and Constellation. Can you believe that list? I mean, back in the day, there was maybe one or two people, and we just want to thank them very much, because honestly, we would not be able to do this without them and the other work that we provide for our patients. To those still with us, if you're having an issue with resources and or direction to an MPN specialist, please let us know, and we'll help in any way that we can. And thank you so much again, Andrew. It was a pleasure to see you again, and hopefully we'll see you in the spring or something, or at ASH. If we're allowed to be there in person.
Absolutely. Can't wait.
Okay. Thank you. Have a great day.
All right. Take care. Thanks, everybody.
Bye. Bye now.